Welcome, everybody. My name is Marty Mascari. I'm with the North Central Texas Area Agency on Aging and the North Central Texas Aging and Disability Resource Center. The Aging and Disability Resource Center is a project of the Area Agency on Aging. We're blessed here today, once again, to have James L. West, our partnership with James L. West, with Hollie Glover and Jamie Cobb Tinsley here. This is another one of our long series of webinars that have just been really, really well received and great stuff. We're thrilled to have this partnership with you all. But before we get started, let's move on to the next slide, if we could, and talk about CEUs. Do you want to go ahead, Jamie?
Absolutely. Thanks, Marty. And we are blessed to be partnering with you. So thank you so much for that. We are also very honored to be able to offer CE credits for nurses, social work, and licensed counselors for this program. 1 hour of CE credit if you attend the full live program. Marty will be sending out a follow-up email either this afternoon or tomorrow, and there will be a link to an evaluation in that email. You must complete that evaluation for us to issue you CE credits. So please click on that link. It should only take a minute or two to complete the evaluation. And then we'll send out the CE certificates within about 3 weeks, 3 to 4 weeks of today's date for you to get that certificate. Thank you.
Just so you know, the certificate will be available or the survey will be available for 1 week until a week from today. But I also want to make the point of you have to, if you want CEUs, you have to do the SurveyMonkey evaluation. That's going to be one link I send you. There's another link to a Google survey that we ask you to please fill out as well. That has to do with our funding sources and our goals and objectives we set forth when we applied for the funding. So there's 2 different surveys, but please note for the CEUs, you have to complete the SurveyMonkey survey. That's a requirement. So I'm going to turn it over to you. If Hollie, it's all yours.
All right. Thank you. Jamie, was there anything else you want to add?
No, just thank you for everybody being here.
All right. Well, thanks, everybody. It's about 2:07. We are going to get started so that we can finish right on time. And we do have a lot to cover today. So we appreciate you being here. I saw lots of names that have been on programs with us before. So we are trying to kind of look at some diseases that maybe you aren't as familiar with that actually do fall under what we call the dementia umbrella. And some of these, again, you may not even be aware that they fall under the dementia umbrella, or they may have just recently been moved under that dementia umbrella. Again, just as a review, when we use that word dementia umbrella, dementia is not the disease. Dementia is a group or a list of symptoms. For example, Alzheimer's disease is the #1 or the most common type of dementia. There's over 130 different types of dementias, Alzheimer's being the most common type. We've talked about vascular, frontotemporal, Lewy body, Parkinson's, and today we're going to talk about 2 diseases that also fall under the dementia umbrella. And we're going to look at statistics, percentages, but ALS and multiple sclerosis do both now fall under the dementia umbrella. And we're going to look, take kind of a deep dive into both of those. Let's start with ALS. And you may have heard of ALS called Lou Gehrig's disease. And we're going to look at, why they started calling it Lou Gehrig's disease. So first, let's start with what is going on whenever somebody does have ALS. It is progressive. Just like the dementias are progressive. It is neurodegenerative, and what it does is it affects those nerve cells. In Greek, that word actually means no muscle nourishment. So the muscles are wasting away. Actually discovered in 1869, and so the muscles do begin to atrophy. The brain's ability to control muscle movement is lost. And so people will start to lose the ability to walk, to speak, to eat, to move, and eventually to be able to breathe. There are 2 different types of ALS. There's sporadic ALS, and this is the one that we see most often. In fact, this is 90 to 95% of all cases is sporadic. And then there is the familial type of ALS, and this is only 5 to 10% of all ALS. Now, if this is in a family, however, there's a 50% chance, though, that the offspring will inherit that gene mutation and may develop the disease. So let's look at some of the symptoms and how this starts. So as you look at these symptoms, you may go, well, this is looking like some other diseases. You can see then how a person might be initially misdiagnosed. It is different from person to person. As I have studied this disease, one of the things that came up most often, and I was reading testimonials from people who have ALS, was that the first thing they noticed was being able to grasp or hold, grasping a pen, holding a cup. They just didn't have the strength to grasp or hold like they could before. They also, many people noticed a change in the pitch or tone of their voice. It has a gradual onset. Another thing that they typically will see is that the senses, sight, touch, hearing, taste, and smell, are not usually affected because the disease does not attach to those neurons. And the bladder is typically not affected either. But look at those that are. Tripping, dropping things, abnormal fatigue in the arms and legs, slurred speech, cramps and twitches. A person, many times when they first present, people will think that it is Parkinson's. They'll start testing and looking at Parkinson's. The progressive loss of muscle control, though, eventually moves into, it affects breathing, swallowing, walking. There's the grasping objects, moving, and eventually breathing. So how in the world do we get a diagnosis? They have to rule out other diseases, and it can take a very, very long time. Most everybody, it's months, and it can even take years because so many folks will get misdiagnosed and be treated for a disease that they don't have. And then, of course, that's not working, nothing's happening, and they have to go back. Some of the things that they will do, that the doctor will do, is they may do this MEG, EMG, the nerve conduction test, blood and urine, a spinal tap, x-rays, MRIs, a muscle biopsy, a nerve biopsy, a thorough neurological exam. And then I found this piece of information, and this is just out there, and they don't really know why. Military veterans are more likely to get ALS, but look at this part. For unknown reasons, ALS impacts veterans regardless of the branch of service, and it affects those that served in peacetime and in wartime. So we can't even go, well, it must be people who were exposed to Agent Orange, or it must be people who were exposed to, it's just across the board veterans. It's also recommended to always get a second opinion because this is so often, it is misdiagnosed. Now, you heard me mention earlier that so many people, that for the most part, I think a lot of people, we just call this Lou Gehrig's. We've heard of it called Lou Gehrig's disease. And this is a picture of Lou Gehrig. And this is a picture of the day that he took himself out of baseball. This was in 1939. And he had started to panic because he knew his body. He knew his body very well. He had played 2,122 consecutive games. He ended up at the Mayo Clinic Keep in mind, this is in 1939. On his 36th birthday, they were able to give him a diagnosis of ALS, and he died 2 years later. And that was somebody who was in top physical condition. Typically, we do see it between the ages of 40 and 70, with the average onset at 55. But look at him. He was 36. It can occur in people in their 20s or 30s, and it's 20% more common in men. So let's look at the stages. We talked earlier about how do people first know something's just not quite right. Muscle weakness, that stiffness, not being able to grip or grasp. It's called muscle wasting. Difficulties with speech or noticing a change in pitch or tone. And then there's the life expectancy, that fourth bullet point. Average life expectancy is 3 years. And I know many of you are already thinking ahead, and we're going to talk about him in just a minute because I know who you're thinking about. We're going to get there in just a minute. Average life expectancy is 3 years. About 20% live 5, 10% live 10, and 5% live 20 years or longer. It's actually been shown that the younger a person is diagnosed with ALS, usually, the longer they will tend to live. Where it's kind of the opposite with some of the other, with like Alzheimer's disease, those dementias, the younger a person is diagnosed, they don't live as long. And there's often periods of up to 2 months with no progression with ALS. Here are some more facts. Over 5,000 people diagnosed every year. Average life expectancy, 2 to 5 years. $2 billion is the estimated cost to develop a new ALS drug. And again, there's not a cure. All of the meds are symptom management or symptom treatment. $250,000 is the estimated out-of-pocket cost for caring for a person with ALS. That was out of pocket. That is somebody with insurance. $250,000. Every 90 minutes, somebody is diagnosed or passes away, and there is no cure. So let's look at treatments. There's 4 approved medications. They are treating symptoms. Support groups have been shown to add to quality of life, and this is support group for the patient to add to quality of life, to help them focus on what they are going through, to have that group of people that's going through the same thing that they are going through. And then that last one, the ALS Association Certified Treatment Center of Excellence. They provide a best practice multidisciplinary care to help manage symptoms, to help maintain independence as long as possible. Studies have shown that participation has prolonged survival and improved quality of life. And then these statistics right here, I just updated on Friday. And this came from ALS.org, and this was all updated in March of this year. So some of these statistics had changed from the last time that we did our program. And this is where we're going to start talking about ALS and dementia. Those top 2 bullet points. So 50% of all people who have ALS will demonstrate some mild to moderate cognitive impairment. And this is just saying that it departs from their baseline. So they may have some of that mild cognitive impairment. 50%, that number had gone up. And then 20% of all ALS patients will meet the criteria for full-blown dementia. That's why it has been moved under the dementia umbrella. Because 20% of all ALS patients will now go on to develop dementia. But look at this next one. ALS.org acknowledges that physicians rarely discuss this with their patients. And this organization is moving to change that, because if the physicians would discuss this with their patients, it would give them time to educate themselves. It would allow them to do things about symptom management, treatment options, end-of-life decisions. They could talk about behavioral challenges that they may face down the road. So this organization is really pushing for physicians to mention that it is a possibility that this could happen 20% of the time. So what does dementia look like in somebody who has ALS? Because this isn't Alzheimer's and this isn't the other types of dementia. So what does it look like? How does it manifest itself? As a matter of fact, they may not have any memory issues. And we tend to think of the word dementia as meaning memory loss. And the word dementia does not mean memory loss. That's a symptom. And they may or may not have memory loss. They may present more like this that you see. They may have executive function impairment with repetition, social withdrawal, slow word finding, and it still falls under dementia because they're having an impairment with two different functions of the brain. And there may not be any memory loss. That may come later. They may start having some judgment impairment, regulating emotions, emotional agitation, reactivity, indifference. And we haven't been able to kind of put our finger on what is going on. Is it just the ALS? And now we know they could be developing ALS and dementia. And what they have found is that people with ALS many times will develop frontal lobe dementia because of destruction of cells up here in the frontal lobe of the brain. That's why the symptoms looked like this, because executive function is right here in the frontal lobe of the brain. And ALS, in many people, is damaging or destroying the frontal lobe. So that second box there, people who develop frontal lobe dementia that have ALS tend to have personality changes and behavior changes that look more like, and there's a list again of some symptoms. So they already have the ALS diagnosis. They then will typically do a CT scan or an MRI because they can see brain atrophy in the frontal lobe to then get the diagnosis of frontal lobe dementia. So you may be thinking to yourself, but what about this guy? You may recognize Stephen Hawking here. You may have even seen the movie about his life. Stephen Hawking lived for 55 years after his diagnosis at the age of 21. He was diagnosed at 21 with ALS. And I've read an awful lot about how was it possible? First of all, how is it possible he was diagnosed at 21 with ALS? And then, How did he live for 21 years? And everything I've read says, first of all, he had a very rare type of ALS, and he had access to exclusive nursing and medical care. He had access to care that most people would not have access to. We're going to watch a short video about what that type of care looks like. And this is a YouTube video that was made by a gentleman who wanted people to see what a day in the life of someone with ALS looks like. And since part of my job here at the West Center is helping take care of caregivers, that is more where my focus went, was on his wife and what is happening to her throughout this day in the life of. So I want us to watch this. It's about 3 minutes.
It might be hard to believe, but in my head, my daily life seems just like every other Tom, Dick, and Harry. I don't open my eyes in the morning and say, "Damn you, ALS." That would be a waste of time and energy. I get up every day with the intention to be as productive as possible. Well, at least after I have some coffee, I feel that way. It's been over 6 years since my body started to crumble from the outside in, but my mindset has always remained the same. I will not let this disease define me. So, I have machines to help me breathe and cough. And I eat through a tube and type with my eyes. Good morning. To me, that's my normal, my life. If you're living life with conviction, faith, and an open heart, I promise you too are going to hit rough waters at some point. It's inevitable. That's the time where you look around and hope you've got the right people in your boat. I know that I don't in fact put my pants on just like the next guy. I've always tended to do things my way. I guess it's that uniqueness that I hope might make a difference in this fight. This is an ugly, tenacious disease. The only way we stand a chance against it is with unwavering determination and teamwork.
So that is ALS. A day in the life, ALS. And we will have time for some questions at the end also. So let's move to MS, to multiple sclerosis. Lots of information on MS as well, and why it has also moved over under the dementia umbrella, because many people live a very normal life with MS. And MS is not itself considered a terminal disease, so a little bit different than ALS. So let's look at what is going on with MS, because look at that. Most people are diagnosed between 20 and 50. So this is a disease that the people who are affected by it, it is much younger, but it is still a disease. It's happening with the brain and the central nervous system. Just like we were talking about earlier, there is so much that is still unknown about this. As I was updating the slides again, with the research, you can find, is it a combination of environmental, genetic abnormalities in a person's immune system? Is it a combination of all of those? They still don't know. Just like with all of the dementias, just like with ALS, if it's not a genetic, what is it? Why do some people get it? Some people don't. We can't predict specific symptoms. We've got a list of symptoms, but we cannot look and go, you will definitely have this happen. We do know that MS is directed at the central nervous system. And on these slides, for the rest of the slides, I believe I do just put CNS, so that is central nervous system. And again, if you haven't already received the slides, you will be receiving the slides. Marty will be putting them in the chat. And what's going on with central nervous system? The immune system causes inflammation, and you may have been hearing a lot about inflammation right now. There's a lot out there about inflammation. One of the reasons we've been talking a lot about inflammation lately, or you may have been seeing it on health reports, is because we've had such a high level of anxiety and depression for the last 2.5 years, which means we've been dumping a lot of cortisol for the last 2.5 years, and it has caused our inflammation in our bodies to rise. And then we have diseases like this. And when we have this inflammation with MS, it damages those areas of the central nervous system, and it can create neurological symptoms. The other thing that happens is scar tissue can start to be related. And we're actually going to look at a brain scan to see why some people start to develop some neurological issues. There's 4 stages of MS, and we're going to look at those. The very first time that somebody has an episode of these neurological symptoms that's caused by inflammation in the central nervous system, it's called a clinically isolated syndrome, or CIS. And for it to even get classified as this, it has to last at least 24 hours. And this is usually before there's a diagnosis. This is the first time something happens. When it is accompanied by brain lesions, the chances of a second episode are very high. And that is typically when we get the diagnosis of the second bullet point. So this is the one that's the most common type. 85% of the time, we have what's called RRMS, relapsing remitting MS. Because the term that many people will use, you'll hear doctors say, people who have MS will say that it will flare, that they will go along, they'll be perfectly fine, they're kind of on a plateau, and it will flare. Heat is not great for MS. So right now in Texas and many other places, as some of you said, heat does not help. Because as you see there, they'll have these relapses or exacerbations, and then there'll be a period of partial or complete recovery. I have worked with people with MS before that would have these flares and might even be in a wheelchair during the time, and then complete recovery in between. There's also secondary progressive MS. This follows that initial relapsing course, and it's characterized by either an active or not active, but that means it's producing a disability over time or not, because this could be leading up to a disability. What all of this is telling us This is a very individualized disease. MS, very individualized. They're not going to look the same. And then there's primary progressive MS. This is about 15% of all. It's the most common in those that are diagnosed after the age of 40. Progressive, meaning it gets worse, neurological function from the onset of symptoms. So let's look at the symptoms. What do they look like? Now, as you look at those symptoms, and then you remember the age that we talked about, that this can be in some younger. Read through those symptoms and think of all of the ways that this could get misdiagnosed. If somebody went in with depression and bladder problems and fatigue and emotional changes, you see where this is heading? MS probably is not at the top of the radar. That's all over the place. And again, just like ALS, just like Alzheimer's, just like many of the dementias, this can take a long time to get a diagnosis because there is not just a test for MS. What they end up doing is they end up ruling out lots of other diseases that look a whole lot like it, especially in the beginning. Some of the things that they are likely going to rule out is Lyme disease, HIV, syphilis, brain tumors, a copper deficiency, a vitamin B deficiency. Going to have to start with a primary care physician that does a very careful medical history. Going to end up at a neurologist. And these are some of the tests that may be done. I added 2 as I updated this as I was doing more research on the disease. And that was the Visual Evoked Potential Test, the VEP, and the OCT. Those were 2 new tests that I found that they've been using them, but these were actual things, tests that were now recommended that I found. But I put 3 things there at the bottom in bold and underlined. So how do we get a diagnosis? We must find evidence of damage in at least 2 separate areas of the central nervous system and, notice and, find evidence that the damage occurred at different points in time and rule out all other possible diagnosis. So you can see where this is not a one and done at the doctor's office. This is going to be months, possibly years again. And again, getting that second opinion is always recommended. So who gets MS? Anybody can develop MS. This one is 2 to 3 times more likely in women, where ALS was more likely in men. It's more common in people who have low vitamin D. It's more common in people who smoke cigarettes. It is more common in Caucasians of Northern European ancestry. And again, it's usually diagnosed at a much younger age. Some other facts about the disease. We talked about difficult to diagnose. It, especially in the beginning, you don't see it. It's called a silent disease or an invisible disease. Heat tends to exacerbate the symptoms. That's what I was saying. Many people right now would be having a flare, or it can cause a flare. And vitamin D treatments have been shown to slow down relapses. So cognitive impairment in MS patients is something that is really being looked at and studied right now. There's a lot of new information that is out on the internet that you can find. And so I found this, and she is talking specifically about cognitive impairment in MS patients. Now, she's going to talk about the difference in a cognitive impairment in someone with MS and a full-blown Alzheimer's type dementia diagnosis, and what the difference is. just like cognitive impairment in ALS or a frontal lobe dementia versus an Alzheimer's type dementia. So this is a very good, again, I think it's about 3 minutes, where she's going to talk about what does cognitive impairment look like in MS, and then we're going to look at some of the statistics.
We think of cognitive impairment usually in the setting of dementias or Alzheimer's. And so people forget how to use objects, they forget who people are, they forget how to do things. That's very different from cognitive impairment with multiple sclerosis. It's a much more subtle change in things like processing speed or information processing speed. So taking in information and being able to use it, being able to remember it, and then what we call episodic memory, meaning forgetting what has happened. So it's not that they forget who people are, but they may not be able to come up with their name right. It's not that they've forgotten that they had a meeting yesterday, they just may not know what happened at the meeting. And it tends to be more slow and progressive, very what we call insidious onset. So you don't tend to necessarily see it occur really quickly. You do see it with relapses, but most of the time it's coming on subtly, such that people can write it off to other things. So I have young children, so I'm not sleeping well, or I'm really busy at work, so of course I'm forgetting things, or I'm getting older, so I need a calendar to remember things. So it can often be already affecting someone's life before it presents to us, because it's easy to say it's something other than MS that's causing symptoms. What's unique about our clinic is that we actually have an MS cognitive clinic, which is specifically designed to assess and treat cognitive impairment in multiple sclerosis. So it's not in the same, it's not happening in the same clinic where we address medications or their physical disability or other things that are going on secondary to their MS. We actually have a clinic that's solely dedicated to assessing where they might be struggling and how that's affecting their family and their work. So what we try to do is we come up with ways to compensate for the cognitive impairment. So I always use the example, it's like using a cane, but instead of using a cane to help with your walking, you're using a cane to help with your thinking. So we come up with techniques that the patients can implement, whether at home or at work, that can make their life easier by compensating for the trouble they're having. It's important to remember that MS does not affect intelligence. They're still the same person they were before. We just need to give them a bit of help in order to be able to do what they used to do. We do have some interventional trials, both the medication as well as a computer program, to see if we can improve cognition over time, but we have not yet had results of those studies, so we don't know if they've been positive. The treatment of MS occurs at a time when people are in the prime of their life, so they're just starting careers, they're just starting to start families. And MS patients are, as a whole, very motivated to look after themselves. They're very motivated to say, what can I do to make this better? What partnership can we develop so that we are working as a team? And I think that's part of what motivates us, is that we can see our patients want help, so we want to help them. I can also see, especially with cognitive impairment, how much of a toll it takes on patients. It's very invisible. It's an invisible symptom. So again, you can see someone using a cane to walk, you understand that they have a disability that they might need help with. But when you're having trouble with your memory, or you're having trouble processing information, it's not easily visible to someone else. So they're less likely to make accommodations for you. So being able to help our patients stay working, being able to still participate in their lives fully is what's very important to us. It's interesting in the cognitive clinic where a lot of the times what I'm doing is validating what the people already feel. So they've already noticed these symptoms, but they think there's something wrong with them. So they think they're not as smart as they used to be, or that they are getting stupid, or that they're not being a good employer or not being a good spouse. So just sometimes identifying where they're struggling and realizing it's not them, it's from their MS, is very rewarding, because it's a huge turning point for the patient to be able to say, oh, okay, now that I know what it is, I can deal with it. And then working through how we can make their life better and how they can sometimes make small changes to accommodate the trouble they're having is a very rewarding thing.
So there are again, some therapies that are out there. There are 9 injectables, 10 oral medications, and there's 4 infusions that are approved. And what these medications are doing, again, they are not curing MS, they are treating symptoms. There are a lot of very famous people or celebrities that have come out and are kind of becoming the face of MS. I've got several of them here. Some you may recognize. I added some more as more and more people are coming forward and saying, you know, I am the face, or I will be the face of MS. And just across the top there, there's Montel Williams. There is, I got to remember everybody's names. There's Clay Walker. This is Ann Romney. This is Christina Applegate. There's Annette Funicello back when she was a Mouseketeer. There's Richard Pryor. He had MS. This is Barbara Jordan. This is Jack Osborne. This is Trevor Bay. He drives for NASCAR. This is Terry Garr. And this is Alan and David Osmond. One of the Osmond brothers and his son also has MS. So MS and dementia, what's going on? Here's the statistic. So 20% of people with ALS will then go on to develop dementia. 22% of those with MS will then go on to develop full-blown, fall under the dementia umbrella, dementia. And what does that look like? Let's look at this one. She was talking about cognitive impairment. So the statistic is that about 66% of people with MS will have some difficulty remembering new information. And most of the time that is associated with just that decreased processing speed of the brain. And like she said, this looks very, very different from what like Alzheimer's looks like. It's not that I'm forgetting you as a person. I know who you are. I just cannot call your name. I know we had a meeting. I can tell you we had a meeting. I just can't tell you what the meeting was about. Different areas of the brain that are being affected. Compromised attention spans due to central nervous system, the damage there. Depression, and depression is a real issue with people with MS, and it needs to be talked about. Depression to the point that it then will start to affect a person's processing. We've got to treat the depression, not hide the depression, treat the depression. Depression can be treated 100% of the time. I did not say cured, I said treated. We can treat symptoms 100% of the time, and we can cure 80% of the time, but you have to do something. And I'm not saying you have to get on antidepressants. There are other ways to treat depression. That's a whole nother program. We'll have to do that program. There's lots of things you can do for depression, and people with MS need to be treating their depression. Patients who do develop the brain lesions are more likely to experience depression, because people with MS may develop brain lesions, they may develop spinal cord lesions. That last bullet point, the amygdala and hippocampus are in the temporal lobes and are involved in learning and memory function. The amygdala is what holds feelings and emotions. The hippocampus holds our facts. And if those are damaged, then of course we are going to see and experience that damage. So let's look at what does this look like. Here's an MRI. And what you see there are brain lesions. So imagine on that brain, whatever is on that area of the brain, there's going to be damage there. So if that's the area of the brain that controls how I process things or my emotions or my feelings or my communication or how I remember, and I've got a lesion there, then that's going to affect me. That's going to affect my loved one. I have one more. This is called MS in 1 minute. These are really good if you have any type. This guy does, he calls them 2-minute neuroscience. I said 1 minute, it's 2 minutes. But he does any type of disease that you can think of. He does them in 2-minute videos. So I want to do this one real quick because he does a great description of what is happening in the brain in 2 minutes. 1 minute, 50 seconds.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss multiple sclerosis. Multiple sclerosis, or MS, is a central nervous system disorder that involves the abrupt appearance of neurological symptoms, which usually occur for the first time between the ages of 20 and 50. The symptoms of MS vary from person to person, and almost any nervous system function can be disrupted in the disease. The most common initial symptoms involve visual disturbances, abnormal sensations, and weakness. The causes of the disease are not fully understood and are thought to involve genetic and environmental factors. Multiple sclerosis is characterized by damage to the myelin sheaths surrounding the axons of neurons in the central nervous system. This myelin damage disrupts the conduction of action potentials along these axons, which is thought to cause many of the symptoms of the disease. The myelin damage can also lead to the deterioration of axons. The brains of MS patients can contain evidence of this damage in the form of plaques or lesions that are visible with some types of neuroimaging. The reason these attacks on a patient's myelin occur is not fully understood, but the damage in MS is most commonly attributed to an autoimmune attack. According to this hypothesis, the immune system in a patient with MS targets myelin, treating it as foreign. This autoimmune attack and the associated inflammatory response leads to damage to myelin, axons, and glial cells. What prompts the autoimmune attack is not known, however, and some have argued that MS is caused by a persistent infection instead. Either way, MS seems to involve excessive immune system activation in some respect, and the drugs that have proven most successful in treating it act to reduce inflammatory or other immune responses.
All right, Jamie, do you want to, here's our information at the West Center, and you can contact me and we will get to questions in just a minute. There's the CEU information again.
I will go back over that if you'd like.
Sure.
Well, and you want me to do that while you look at the questions?
Sure, yeah.
Yeah, that's great. I just want to go over, for those of you that are looking to get CEUs today, the CEUs are being offered for licensed nurses, licensed social workers, licensed professional counselors, and certified attendants. I believe just in the state of Texas. Is that right?
That is right.
That's right. I just want to make sure. You must complete the entire webinar to be eligible. You must complete the SurveyMonkey evaluation form. The link to the SurveyMonkey will be emailed to you in the follow-up email that I will be sending out later today. Please note that if you want CEUs, you must complete the SurveyMonkey evaluation. There was some misunderstanding about this recently, and I want to make sure that that's clear. The SurveyMonkey will be evaluation will be up for 7 days to this, and then the certificate should be sent out within about 3 weeks after that closes, that closing date, which is 6/21. In addition to the SurveyMonkey evaluation, we also have a Google survey evaluation that is set to pop up as you log off today from Zoom. But if it doesn't pop up, but I realize some companies have blockers, then you will also receive that survey, the Google survey, I'm sorry, in the follow-up email. And that is one we ask you to complete, because that helps us with our funding objectives that we filled out in order to apply for the funding to put on these webinars. So that is that.
And that's the next one we're going to do.
I'm sorry. Okay. Yeah. I'm sorry. Huntington's disease. I didn't know if you want to go back to questions first. Huntington's disease, Lyme disease, and stress, how they affect the brain, will be on Tuesday, July the 12th from 2 to 3. We look forward to having you there. There will be a link to the flyer for that presentation that will be sent out also in the follow-up email.
Okay. Now, let me look at some questions real quick.
There you go. I see. I now understand what you were trying to get to.
Okay.
Get away from it.
So I saw this. I've heard that women who lived their first 15 years in a cooler climate and were overweight at a young age were more commonly diagnosed with MS. Have you heard of this, Holly? That I have not. I did read that people who lived, who had more sun exposure as younger adults were less likely to develop MS, but I haven't seen that one about cooler climate and being overweight. That's interesting. I haven't seen that though. That might be worth looking at. Are there neurocognitive MS clinics in our area? Antoinette is asking, or if you are in the DFW area, yes, there are. There are. And you can, there are people who specialize in MS, as a matter of fact, in the DFW area. Most any big cities, you will find people who specialize. Let's see, has there been any research into why military are at such a high risk? And then I noted the stats for military personnel impacted as 60%. Any studies in diet, since one common element in the military is boot camp and diet, but not the weight. One problem's finding one. Yeah. Or having problems finding. Okay. Whenever I read that about the military, that I started researching it myself, and every single article I came across said that it was unknown, that they did not know why, and that it was across the board. It didn't matter which branch of the service it was, and that it did not matter if it was peacetime or wartime, that it was people in the military. So that is a great, I wonder, studies in diet, since the common element in military is boot camp and diet. Yeah. So it's definitely something that there's research. It's the vaccinations. Look, there's another one, vaccinations. That's across the board. It's something that they are looking at because there are articles out there about it now, and there are studies being done about it now. So it's definitely coming up. They're looking into it. Boy, that vaccination might really be something to look at. Yes, the MS neurologist, UNT Health Science Center at Fort Worth, point you in the right direction. Yeah, good idea. Great, good questions. We appreciate everybody being here. Like Marty said, next month, we're going to go into 3 more that we're going to look at that fall under the dementia umbrella. Huntington's disease falls under the dementia umbrella. Lyme disease can slide in there. And then, who knew? Stress can lead to dementia. What? Anybody had any stress the last couple of years? We might need to do something about it.
And Holly, there was a question in the Q&A function more related to ALS. You can address that.
The caregiver can focus on self-care and mental health, warning signs, prevention, trust, and return for individuals. Real-time and practical tools and resources, toolkits for ways to touch. Oh, I have got that resource, the ALS. Brenda, will you email me? Brenda, if you will email me at hglover@jameslwest.org, and I will send you a resource if you'll send me that. But yes, practical tools and resources toolkit, because I found a website. That's where I got a lot of information. In fact, I think it's on one of the slides that I took it from. it may be ALS.org, ALS.org. On ALS.org, there's a lot of great information. But yeah, if you will email me, I'll also see what I can find. But ALS.org, tons of information. All right. Thanks, everybody.
You even have a comment in, and I don't know if it's Hawaiian. What would be the language of the native Hawaiians? But there's a comment that should make you feel cooler already. You've got a nice compliment coming to you from Hawaii.
Right.
There you go.
Very good. Very good. I'm just so cool now.
Yes.
98. Got my fan over here. Got my ice water. I'm good. All right. Thanks, everybody. It's good to see everyone again. See you next month.
Holly, Jamie, thank you so much. Just very, 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 very impressive. Great stuff. Thank you all for joining us. Look for your follow-up email. We'll get that out to you. If you have any questions, you can send them to me or send them to Holly. One way or the other, we'll get them to the right place. But thank you for joining us, and y'all have a wonderful day.